Hello everyone here. Today we are coming to discuss an important issues about IBD, present and future treatment of IBD and how we upgrade ourselves according to the patient condition. We have, as all know, a traditional combination therapy for the treatment of the patient with IBD, even giving steroid plus immunomodulators or even immunomodulators plus biologics. In some cases, we are working according to the common theory, which it is one size fits all, and this is a very critical zone of idea, as the high risk patients may be in refractory to refractory form of IBD and uncontrolled external symptoms of IBD, maybe have failed to be treated adequately, and we have to do an active treatment, dual biologics or biologics plus small molecules. In future, we are doing in another methods. We are trying to tailored approach or tailored therapy. We can give an immunomodulator therapy plus biologics, immunomodulator plus small molecules, biologics plus small molecules, and we have to do a form of dual biologics in addition to immunomodulator therapy for patient with a high risk patient refractory IBD extant symptoms, and patient we have divided the form of response of IBD in two different groups, and then we will maintain the patient to a monotherapy or an active therapy, and we will achieve a very important essential point, which it is a molecular healing and histopathological improvement in the patient, which delays the dysplasia and maybe retard the occurrence of malignancy or cancer caused in such patient. Usually we have a theory for organization of our RDA during dealing with a patient with IBD. We have a pre-biological initiation, confirmation of IBD, and the rule out of the alternative etiological diseases, infection, ischemia, non-steroidal, and something like this. Address a unique challenge for the patient, the goal of the care, and the frailty and cognitive deficient or deficit which may be occur, malnutrition, polypharmacy, in multi-drugs over the counter may be present in the patient, the comorbidity, the patient maybe have another problems other than the IBD. We have also to know what is the social support the patient receiving from the family. All of this are a unique challenge during the treatment of the IBD. Biologics pre-request, we have to do a skin test and quantiferon test and hepatitis serology and hepatitis B or C, also for Epstein-Barr virus and cytomegalovirus. And cytomegalovirus may be one of main etiological factor for exacerbation of IBD. It is an cytomegalovirus-induced colitis or even with a Clostridium difficile. Some vaccination may be needed, biologics like pneumococcal vaccine, influenza vaccine, and the recombinant shingles vaccine. All of these we have to consider before starting biologics. And if we are starting biologics, we have a mapping for anti-TNF or anti-integrins or anti-interleukin 12, 23, anti-TNF, which may be increases the risk of the respiratory disorder and the opportunistic infection in some patients, and also it is a predisposing factor for a lymphoproliferative disorders in some cases. And we have a contraindication for starting the treatment of the biological therapy or anti-TNF, especially in the patient we have a previous malignancy of the skin or previous cancer or congestive heart failure may be intolerable for starting anti-TNF. We consider it essentially for the patient with preanal disease, fistulized Crohn's, patient having extraintestinal disease as bioderma gangrenosum, ankylosing spondylitis, and something like this. Anti-integrins, it is a gut specific, but dozimab, Entevio, it is very specific, and we used it usually in the anti-TNF failure. And it is considered also for luminal diseases. No activity against extra intestine symptom, unfortunately. And we have also to use anti-interleukin 12 and 23, ustekinumab, limited to the elderly, and limited data to be used in elderly, and now it is approved to be used even in children. And consider if there is a concomitant psoriasis, we have to start an pyostigmine. Post biologic initiation, we have to give a care for the adverse events or adverse side effects which may be occur in such patient, like infusional reaction, injection, and hepatotoxic effect. Optimize the treatment for the patient and avoid or minimize the use of the steroid. Preventive care in this patient is very essential. Annual skin checking and age appropriate cancer screening, annual influenza vaccination may be required. Optimize the nutrition of this patient and monitor the weight of the patient. Co-management of the care, primary care, geriatrics are very essential. Specialist in the rheumatology or cardiologist or hemato-oncologist and endocrinologist may be essential to follow the patient on the biologics to avoid the side effects which may be occur during the treatment. Many thanks and goodbye.